Okay, we are having participants enter, and I will take just a moment to let them all enter the room, and then we will get started. Good, I think we've reached a critical mass where we can get going. Welcome, everybody. We had a slide we'll be putting up shortly once Tyler joins, but I just want to say good morning. Thank you for joining us. Welcome to the webinar. I am going to get us started. So good day to everyone joining. This is our third webinar focused on addressing the health of people who work in and are detained in correctional facilities during the COVID-19 pandemic. Our first webinar focused on innovative strategies to preventing outbreaks during the first peak of the pandemic. Our second focused on prioritizing incarcerated people and correctional staff for COVID-19 vaccines in state and national distribution plans. And now we are here today to discuss approaches to ensuring adequate vaccine uptake. I'm Lisa Puglisi. I'm an internist at Yale School of Medicine with a clinical practice that is focused entirely on the care of people who return to the community after incarceration. I'm the Director of Education at the SEICHE Center for Health and Justice here at Yale, and I am joined today by my colleagues, Dr. Emily Wong, who is the Executive Director of the Center, and Tyler Harvey, who is our Center Administrator, to bring you this webinar. We are grateful that you took time out of your busy day to learn with us and discuss what we see as a critical and urgent issue of importance, that is the health of people who are incarcerated, those who work in correctional facilities, and the health of the families and communities in which they live and to which they return. We are now over 3 months into the rollout of COVID-19 vaccines nationally, and state plans to prioritize incarcerated people and staff are all over the place, as are rates of uptake and the data that is made available for analysis and monitoring. So while we don't know for certain what percentage of incarcerated people and staff have been vaccinated in most of the nation's jails and state prison systems, we do know two things. One is that we need a high rate of immunization to help us reach herd immunity. A very rough calculation overall is 86%. And vaccinating the correctional ecosystem, i.e. detained people and the staff who work inside, is critical to achieving this herd immunity in many communities, given the interplay of between correctional and community health. The other thing we know is that there is a good deal of concern about vaccine behaviors that will lead people to not accept a vaccine even once they get access to it. A survey of 136 incarcerated people conducted by the Marshall Report found that even amongst people who felt wary of the vaccine, most respondents said they'd get vaccinated if their questions were answered, if their friends and family said it was safe, and if guards received their immunizations first. Yet, rates of correctional staff vaccine uptake that are being reported thus far are low, roughly around 50% in states such as Massachusetts, Iowa, and California. And that's 50% anticipate accepting a vaccine. In Rhode Island, 30% of prison staff have refused the vaccine, a rate that's higher than that amongst incarcerated people in that state. The reasons for this are likely many, but one that has come up in a few reports is distrust of the correctional system. And this may be the commonality between both parties. With close to 400,000 people in prisons who have tested positive for COVID and over 100,000 staff, in addition to necessary approaches such as decarceration, which is crucial, there is no way out of this pandemic that excludes wide-scale vaccination. How to increase uptake in an ethical way is the pressing question at hand. And thus we have three aims today with this webinar, and those are to identify promising approaches to improving vaccine uptake amongst incarcerated people and correctional staff, to identify correctional system approaches to addressing COVID-19 vaccine concerns among correctional staff and incarcerated people, and to think through the ethical and legal considerations for such strategies. To accomplish these goals, we will be hearing from 6 speakers whose expertise represents a broad and varied lens to thinking through approaches to improving vaccine uptake for this population. And we are really honored to have them all here with us today. That being said, we also value the expertise in the audience, which is surely even more varied. And so we encourage you to share questions in the chat and your viewpoints, and we have dedicated over the last half hour to addressing these questions with the panel. We are also grateful to our colleagues and student members at the Yale Prison Education Initiative and the Yale Undergraduate Prison Project, who are helping us to transcribe this webinar, which will allow us to send it into incarcerated students all over the country so that they too can learn from this discourse. To increase the reach of this webinar, we are also hoping to offer the translation in Spanish for those in the audience who are Spanish speaking only or who prefer to process information in Spanish. And here's a slide here that will show people how to access translation. Our interpreter is not on yet, so I will put something in the chat once he arrives and is available. So now without further ado, let's get down to the good stuff. Our first speaker will be Dr. Rupali Limay. She is a social and behavioral scientist and health communications scholar and is a faculty member at the Johns Hopkins Bloomberg School of Public Health in the departments of international health, epidemiology, and health behavior and society. Widely seen as an expert in vaccine behavior and decision-making, including vaccine hesitancy and acceptance, she serves as the director of behavioral and implementation science at the International Vaccine Access Center, as well as the associate director for behavioral research at the Institute for Vaccine Safety. She is specifically also interested in how health information can best be communicated to individuals in different contexts and through different channels. She will be talking us through a framework for understanding existing strategies around vaccine uptake. So Dr. Limay, please help us get started in thinking through evidence-based strategies to increase vaccine acceptance and uptake in the general population, and how those may give us a framework to thinking about vaccine behaviors amongst incarcerated people and staff in prisons and jails. I will turn it over to you.
Thanks so much, Lisa, and it's nice to meet everyone and great to see so many attendees as well. And please feel free to ask questions. I'll try to get to them as I can. I'll try to keep my remarks relatively short because I'd like to definitely have some time for some Q&A. I want to start a little bit, I think, with a little bit of my background so you understand. I've been studying vaccine science for about the last 7 years. I am in no way, shape, or form have any sort of affiliation with any sort of pharmaceutical company. I'm an independent researcher that works at an academic institution. And what we really try to do is make sure that people have the information that they need to make a decision related to vaccines. So I have no conflicts to disclose. I want to start a little bit with, I think, some pain points if we can, and then end on a little bit of an optimistic note. I think that many of you are likely dealing with a lot of confusion related to vaccine access. And one thing that I can say with regards to how the rollout process has gone, I'm sure many of you have heard that there have been a number of challenges, and that's because a number of reasons. So the FDA can approve a product, i.e. the 3 vaccine products that we currently have on the market, that went through an independent review process, and those were brought to market, right? So there's the Pfizer, there's Moderna, and there's Johnson & Johnson. The CDC can then provide a recommendation and can say, we recommend adults over the age of 18 that don't have any sort of reason to not get a vaccine to get the vaccine. The problem then is that implementation lies with the states, and that's where we're seeing a lot of confusion. You likely have heard from friends and family members that have said, guess what? It's really easy for me to sign up to get a vaccine, versus friends in other states that are saying it's impossible for me to get a vaccine. And that just has to do with the way that our country is set up with regards to federalism. So states really determine not only the allocation process, but also who to prioritize. When I talk about prioritization, I think most of us are now familiar with the different phases, phase 1A, 1B, 1C, and phase 2. And most states are somewhere between 1A and 1C, still in most of the country, meaning that generally the general population is not really eligible in most states to get the vaccine. Many of us that work in vaccine science inputted into this prioritization process, and many of us advocated for incarcerated populations as well as long-term care health facilities, which I'm sure you have heard about, to be in the top in terms of allocation. The reason that we wanted to do this is that we want to make sure that prioritization and allocation is based on an evidence-based process. To me, people that are more at risk of exposure, of being in contact with COVID-19, they should be higher up on the list. So just so you understand how this process, this was a messy process that many of us inputted into. The problem that we're really seeing is states implement this process. The second sort of pain point that I want to talk about is distribution. As many of you probably have seen, depending on what state you are from, there are different ways you can get the vaccine. I live in the state of Virginia. You know, we have heard that essentially pharmacies can provide the vaccine, but can only provide the vaccine to those that are 65 and older right now. It's causing a lot of confusion as people are trying to figure out, how do I get the vaccine? What is the best way for me to get the vaccine? How do I sign up a friend that might be more at risk of exposure? So these are sort of, I think, some of the pain points that we're dealing with now. I'm going to talk now very briefly about vaccine hesitancy, which is what I have been studying for the last 6 or 7 years. So I think many of you know vaccine behavior lies on a continuum. We have individuals that refuse some vaccines. We have individuals that accept some vaccines but might have questions about those vaccines. And then we have a small proportion of individuals here in the States that are fundamentally philosophically opposed to vaccines. It's a very small proportion of the US population. We have been studying their behaviors for a long time, trying to understand what are the reasons why people might be reluctant to get a vaccine, and what are the ways in which we can communicate to these individuals the information that they need to make an informed decision. So pre-COVID, I would argue that there were essentially 4 reasons we heard from individuals as to why they did not want to get any vaccine, whether that's the COVID vaccine or any vaccine. The first has to do with vaccine ingredients. People had questions about how the vaccines were developed, what sort of ingredients were included. The second issue was really this misperception that vaccines can cause a severe adverse event such as autism. I will say that this misperception has been soundly refuted in more than 100 clinical studies at this point that have shown that there is absolutely no link between vaccines and autism. However, this idea and this misperception still persists, and we continue to hear this. The third issue that we have heard is this idea of risk perception. So again, think pre-COVID. If I said to you, hey, you know what? When was the last time you got a measles vaccine? You might look at me and say, you know what? I have no idea. Part of that has to do with the fact that you don't think measles is around. You're not susceptible to measles. And let's say you contracted measles, you might not think it's severe enough for you to take the vaccine. So risk perception was a real challenge. The fourth issue really had to do with schedules, meaning how many vaccines people were given at a time. So, you know, at different ages, the CDC recommends that you get, for example, the MMR vaccine, the Tdap vaccine. As you get older, they recommend the HPV vaccine, the shingles vaccine. And people really had some questions and concerns about the number of vaccines that they were being recommended and asked to get. So we've seen a bit of a shift. We have been tracking attitudes towards the COVID-19 vaccines actually since the start of the pandemic, when we realized that potentially there could be a vaccine for COVID. So since about a year, we've been looking at attitudes. And what we have found is additional drivers of why people might be reluctant. So the number one issue that we are hearing is that people are saying that the process was politicized. And what I mean by that is that, as many of you know, the way that the vaccines were developed were through a program called Operation Warp Speed. Many feel as though that this expedited process, it conveys that some regulatory corners were cut, for example. This is not the case, and I'm happy to talk about the process of how clinical trials unfolded with regards to the COVID-19 vaccine products, but this is a perception that people have. The second issue that we're really seeing is that people are very much concerned about the expedited process. They say other vaccines took years, sometimes 10 to 15 years to develop. How were scientists able to develop a product to prevent COVID-19 in a year, and therefore have questions about the process? The third, I think, larger broad piece that Lisa touched upon was this idea of trust. We have seen a decline in trust towards healthcare providers. This has been going on since the early 2000s. And if you track trust in healthcare providers over time, we will continue to see a decline. What I specifically work on with regards to COVID-19 vaccine uptake is uptake and disparities among communities of color. This disparity is even larger and is very disproportionate. When I'm speaking with especially communities of color, African Americans, as well as Hispanics, there are a lot of concerns, rightly so, because of historical trauma related to medical experimentation. And people are really worried that individuals such as themselves were not represented in the clinical trials. And therefore, they do not feel comfortable getting the vaccine because they do not feel that there were enough individuals like them that have gotten the vaccine so far. So that's really been, I think, the key issue that we have been struggling with is how do we communicate to populations that have not only disparities with regards to vaccine uptake, but also have disparities related to COVID. I think many of you know African American communities in particular, as well as Hispanic communities, are much more likely to have comorbidities that would put them at higher risk for severe COVID and at higher risk for death related to COVID. And so it's a real challenge for those of us working in this space to really work with these communities hand in hand to make sure, again, they have the information that they need to make an informed decision as to whether or not to get a vaccine. So what can we do? So I have been working in this space, as I mentioned. We're now working in this space related to COVID. Previous to COVID, we worked with pregnant women. We worked with childhood vaccines. We've done a lot of work in this space. And I think there's some key things we can think about. One has to do with this idea of how do we build trust through empathy? And if I could, I'll give a little bit of a personal anecdote, if you will. I started working in this space when I was pregnant with my second child. And I remember having a discussion with other doctors that had been working in vaccines for 20 plus years. I had a lot of questions about the childhood vaccine schedule. And several of them turned to me and asked me, they said, Rupali, are you vaccine hesitant? And I said, no, I am a mom that has questions like every other individual that I have spoken to. And therein lies the problem. This idea that we are dismissive of people that have concerns, that we're not empathetic to people that have concerns. And to me, this is the biggest challenge that we really need to overcome. And when we apply an empathy-based lens, that's when we will actually be able to see some change. And that's what we have started to do, is how do we build trust through empathy? Understanding that we've been living in an uncertain time for a year, people are scared. We need to be human when we're having these interactions and talking about the vaccine. The second thing I will say is related to transparency. I'm at the Johns Hopkins University, which is based in Baltimore. We worked very closely with the mayor's office, as well as the governor's office, very early on in the pandemic with their press briefings that both of them had, and we worked with their team. One recommendation that we gave to them is that if they were having daily press briefings or if they had them 3 times a week, it was very, very important for them to come up and say, guess what? Here's what we know. Here's what we don't know. And here's what we're trying to figure out for you. So being very transparent on where people were in the process, if tests were available at the time, when testing would be available, and when vaccines would be available for particular segments of the population. Another piece that I would say that we focused on is this idea of communicating often. One thing that we are hearing very much with some of the states that we are working with is that they might hear from a state, let's say a state public health department, but they hear very infrequently from them. So communicating as often as possible, again, even if it's just to say, I don't have any new information for you today, goes a long way with regards to building that trust. The other piece that I would very much mention here is, again, to end on something called a personalized recommendation. And what I mean by that is, when I talk to a lot of parents, or if I talk to individuals that haven't gotten the COVID vaccine and they have questions for me, I always say, here's what I know. I study vaccine science. I study this through an unbiased perspective. because I am not related to any sort of pharmaceutical company. But here's what I would do, and here's how I have done this in the past, and here's how I've advised, for example, friends and family. So they get a sense of this is what you would do as a person and not necessarily as a medical or a public health professional. So I will stop there. I don't want to take more time, but just wanted to say in terms of some of the key lessons, again, would be trust through empathy. Again, this sounds to me, it sounds very basic, but you would be amazed at how many people have not been engaging in this. Transparency, so being clear on what you know and what you don't know. Communicating often, even if that's an update to say, guess what, we don't have any new updates for you right now. And then really personalizing the recommendation to talk about, hey, guess what, I'm a public health person. This is what I have done. This is what I've recommended my friends and family to do. And if you have questions, to feel free to ask me those questions so I can tell you a little bit about my experience. So I will pause there and turn it back over to Lisa. Again, thank you for giving me the opportunity to be here. I'm very excited to learn, I think, more about from the other panelists as well as the other participants. So back over to you, Lisa.
Thank you so much. And for all participants, everybody watching, the panelists will stay on throughout the entire webinar, so we'll be available for questions towards the end. Thank you so much. So we heard again, trust through empathy, transparency, frequent communication, and personalized recommendations. And moving from there, we're going to turn it over and open the conversation to our next panelist group. They're the duo in the back there that are a little small. But we are joined by Secretary John Wetzel of the Pennsylvania Department of Corrections. Secretary Wetzel was chosen to head the PADOC in January of 2011 by Governor Corbett, following a 22-year career in county corrections. With 30 years of experience in the corrections field, he served as chair of the Council of State Government's Justice Center's executive board, of which he is now a member. He also served as the recent president of the Correctional Leaders Association, formerly ASCA, and a member of Harvard's executive session on community corrections. Secretary Wetzel is joined by Dr. Christian Conti, with whom he has been doing some COVID educational work. Dr. Conti is a licensed professional counselor who received his PhD from Duquesne University in counselor education and supervision, and a master's in community agency counseling. He created yield theory, an evidence-based approach to communication rooted in compassion and conscious education. Dr. Conti is the author of 8 books, including his latest, Walking Through Anger. Together, they will speak to us about their on-the-ground experiences with COVID-19 vaccine strategies within the Pennsylvania Department of Correction for incarcerated individuals and staff. So first, Secretary Wetzel, what strategies are currently being engaged within the PADOC to address concerns around COVID-19 vaccines for both staff and incarcerated individuals?
All right, well, thank you very much. And I'm just going to kind of quick contextualize it and then kick it to the smart guy next to me to go. But first of all, I'd like to thank Dr. LeMay on behalf of all of us. It made me feel so good that you've been working on vaccines for 7 years. Like, it was just the coolest thing to hear. And we'd be happy in Pennsylvania to share. We've done a lot of polling and that kind of stuff. And we're working with Emily, so I'd be happy to download all our stuff. But I got to tell you, one of the things that you point out that was so challenging, especially early on, is that we didn't really have good information. And fortunately, we brought in a public health doctor and Dr. Conti had been working with to kind of make guesses, frankly, at what to do. But let me just start with this context. I think COVID, to me, has pointed out something that I've known forever, but really never say it out loud. And that's, frankly, that the fate and health of our staff and incarcerated individuals is inextricably linked. And so we got to start with that. Like, this us versus them, which we've devolved into, it got to stop. Like, listen, we need everybody. Our goal is that everyone volunteers to get the vaccine. Whatever we got to do to convince them or whatever, that's what we have to do. And that's really our framing for this. We decided early on we were going to explain the why, even though we didn't have time to do it. to the doctor's point, because there were so many unknowns, I literally told my leadership team, this is what we're going to do today. We may change everything tomorrow. I don't know what information is going to be coming out of DC, but we're just going to talk every day until we figure it out. COVID has been a pressure test, and anywhere where systems are weak, you became weaker and it became a crisis. And so from day one, we started on focusing and being strategic around communications. And Dr. Conti is going to talk about, we started fireside chats where leadership, and we evolved to leadership and a credible messenger from the population would answer questions weekly on video. That's still going on. So then we were just able to plug in the vaccinations to this communications infrastructure. And I think so I think deciding that communications was a risk early and being deliberate about that has paid off. And it's paid off because we had 3 facilities in 1A. At those 3 facilities, our incarcerated population is about 75%. Our staff overall is about 35%. I'm guessing we're about 15 or 20% underreporting with staff. I think that's one of the things. It's hard to quantify that, but we have some staff who are taking it and not letting us know because they can get it in the community. The incarcerated population at 75%, I anticipate hitting 80% system-wide because of this communications infrastructure. And we take this approach. We poll first, survey, we pilot at a couple sites, we affirm or disaffirm the polling, and then we do a statewide strategy. And that's where Dr. Conti comes in. Let me just mention one thing around incentives. We attempted to do statewide incentives for staff and the incarcerated population. We're a union state, so statewide, we're still negotiating with a bunch of different unions. But I will tell you this, we should be incentivizing everybody to get the vaccine. For a staff member, forget about everything else. Staff member, $5,000 for a staff member who's positive. That doesn't include overtime costs to replace them. For an incarcerated individual who goes to the hospital, it's more than $20,000. We're giving the incarcerated population $25 incentive. That cost benefit works. And I think we got to get beyond rhetoric and beyond this stuff. They're human beings. We want everybody to get vaccinated. If a small incentive gets more people vaccinated, more people healthy, and we get to herd immunity, we should do everything we can. Dr. Conti, go from there.
All right. So first of all, thank you. I appreciate being here with you. I'm always honored to sit next to this guy because he's honestly the best leader I ever met. To hear Dr. LeMay speak it was energizing for me because what you said truly resonates with me. We've never met. I'm just first time getting to hear you. But you mentioned about how sometimes what we're doing, it sounds obvious. But sometimes that's the genius, is when we can point out the things that are really obvious. And I've spent a career devoted toward trying to make things really simple for people. And I was in one of our institutions during the onset of this, and it hit me as I was talking to some of the men that they were just not knowing what was going on. And so I speak all over the country and I fly a lot. And I don't really enjoy flying as much as I do it. And sometimes when there's turbulence, I just always want the pilot to come on and say, hey, listen, no big deal. It's just turbulence. Cool, thanks. It might be an irrational fear to me, but I would just like to hear that. So I was at this institution. I sat down with the superintendent and I said, let's do a fireside chat. Let's get on. Let's tell the population what's going on, what decisions are being made. When I shared that, the moment I shared that with Secretary Wetzel, he saw that vision, said, let's do this every institution every week. And they have these fireside chats allow institutions to do exactly what Dr. LeMay said in terms of letting people know what's going on. If there's no new information, at least let them know that. But then more than that, our system, I feel very proud to be in a system where they said, let's start listening to the individuals who are incarcerated, let them share what they're saying on the channels. So that was huge. And I created this thing called yield theory, which is about genuinely meeting people where they are and attempting to see the world from their perspective. And I even say it's not just a matter of walking a mile in their shoes, but imagine that you had their cognitive functioning, their affective range, their life experiences. I really believe that if I had all of that, I would make every single decision that that person has made. And it allows me to wipe away judgment and genuinely sit with people. I have this metaphor that we use when we're trying to understand people's perspectives, when we're trying to see where people are genuinely coming from. I humbly call it the Conti box, but really what it's about is this. It's about like, I can only ever see a given side, maybe two sides of a box in any moment. So that means if I want to hear someone else, I can never see their side. I have to be able to put aside my ego and listen with genuine humility and curiosity. And I have heard things. For instance, I've heard experts will come on and say, calls people's perspectives a conspiracy theory, and then it's dismissive and it's invalidating. And there are these people, and this is their perspective. So why are we dismissing it up front and then belittling it? So to me, I look and I say, whatever, one thing led to the next in the story of all of our lives. And when we able to listen to people as though, tell me your side of the box, not that this is this little conspiracy, but let's listen to it. And this is exactly what we did. There's a difference between listening in sales to like, hey, I'm going to listen, but I really just want to sell you something, and listening to really understand someone's side of the box. So I would say to listen with the goal to convince is probably sales. To listen with the goal to really just understand, that's yield theory.
Let me hop in. So as far as distribution, we go by site as opposed to spreading it out, because one of the things is we have limited medical resources. So we've actually brought contracts on. So we have vaccination teams that go in and vaccinate a facility. We try to do it in a day or two. And then for refusers, so everyone gets a proactive offer. For refusers, we then have medical personnel as well as either hostage negotiators or therapists to just talk through and try to understand that. One of the most important parts for me is getting that information back and then letting Dr. Conti, and he works with our team, adjust to answer the specific questions people have, and then figure out who the credible messengers are to put their face on it. So thank you for your time. We wanted to take the doctor's lead and kind of hit you, and then get lots of time in the back end to answer questions. Thank you.
Thank you. We have 2 more minutes, and I'm going to ask you to clarify for people from correctional leaders who are on, what exactly are these fireside chats? I haven't seen too many fireplaces in the correctional facilities I've been in. So can you explain a little bit just what these fireside chats are so people have a clear understanding?
Yes, definitely. So the fireside chats occur. The superintendent of the institution, or one of the leaders of the institution, sits down every week to share with the population, this is what's going on. These are the reasons why we're making these decisions, and also address any questions that they may have. And then when you do it this way, you're minimizing the miscommunications because you're able to address everyone at once. And this is one of the reasons why firesides are so important, because by the time you pass information block to block, it can change. But when you can jump on the inmate channel and speak to everyone at once, that clarifies things.
And I would just add a very specific example. So one of the things we also do is if there's a big change system-wide, it has to come from me. And what I found is we'd put a memo out and just tell the facilities, hey, put a memo out and change this. Then I'd go out to the facilities and I'd have incarcerated individuals come up to me with the memo and say, hey, did you say this, or are they screwing with us locally? So that was really, it's one of the reasons why I think it's so important that guys like me actually leave the office and get out in the field. It is really a message to me that, like, if it's a big change that everybody gets, they need to hear it from me or one of my executive deputies. So that we have local fireside chats, and then Doc will come in and shoot a video with one of the leadership teams if there's a big system-wide change.
And what about, what are strategies that you have used, or have you started using strategies to engage correctional officers more as well?
We're actually formulating that right now. We because of the distribution, it was like 1A, long-term care facilities and medical staff. Our staff fell into 1B, but because of the distribution strategy and the change in administrations, all of which played into like a chaotic January and February, we focused on the 1A facilities, and we also set up an informal network where some hospital systems around the state were providing vaccines to first responders. So we helped our staff who wanted it get it now, get it then. We've also done some focus groups, and in the next week, we'll be rolling out our specific strategy for increasing staff, and it's the same theme, credible messengers. But we've also, last Friday, we did a memorial service, a virtual memorial service. We've had 6 correctional staff pass away. We had our 7th this week. And part of the purpose of doing the memorial service is to recognize both the staff and incarcerated individuals who passed, but also really highlight that this is a real thing. And that I know there's angst, and listen, Black and brown people have a reason to not trust the criminal justice system, right? I mean, let's just introduce the elephant in the room. But the reality is, this is a classic cut off your nose to spite your face. Like, I eat hot dogs. I'm getting a vaccine, man. You know what I mean? Like, you find a narrative in your head to get to yes. And that's really my message to folks.
And I just want to end on this piece. As Secretary Wetzel said, listening first by polling people, taking those focus groups, and then we really get a sense of what they're thinking.
Secretary Wetzel, I just wanted to ask another question that's in the chat that perhaps y'all can't see, but you have shared with us some incentives, some thoughtful ways both to engage people with empathy and also correctional officers. Are there any circumstances right now, either in your facility and others in the country, perhaps that are more punitive, like transferring folks, not giving people access to services? Have y'all, considered that? What are your thought processes on that?
Yeah, I think I'm not aware of any, but I'll tell you, over the past year, we've had so much stuff going on that I'm not as connected to other systems, but I have not heard like a punitive approach yet. I'm sure you're going to hear some one-offs around punitive approaches, right? This is a risk for this kind of stuff when you're in a kind of a structure like a criminal justice structure. Oftentimes, punitive approach is the default, but I haven't heard that yet. Again, I think it's a risk that we need to, I think it's important we introduce risks, we factor them and try to find a way to work around them.
Thank you. I'm going to pause this conversation there and move on to our next panelist, and I'm sure there will be many more questions afterwards. So moving on next, we will hear from Shannon Ross. Mr. Ross is the president of the nonprofit organization, The Community, which focuses on promoting the successes, humanity, and agency of people with criminal records by inreach and outreach, including a newsletter, which is read by over half of people in the Wisconsin prison system, which they publish. Mr. Ross himself served 17 years in prison in Wisconsin and went in as a teenager. He created The Community in 2014 and has run it ever since, with the help of friends and family, while finishing his bachelor's degree in business administration. Upon his release in 2020, he began a fellowship as a grad student of University of Wisconsin-Milwaukee and is a community fellow with the Wisconsin Decarceration Platform. He is also a member of Reentry Rising MKE and Unlock Higher Ed. He will be speaking to us about the role of formerly incarcerated individuals in COVID-19 vaccine education and challenges associated with educating from the outside. So, Shannon, can you tell us more about the initiatives you've engaged in surrounding COVID-19 vaccine education and what sorts of challenges and successes you've encountered?
Yeah, absolutely. And thank you for having this. And I'm learning a lot myself here today too, because we're in the process right now of putting together a comprehensive packet with graphics and commentary and a video series to hopefully get into the DOC. Some of that is right now uneven as to where the funding is going to come forward and if it's going to get allowed, but the talks are going on. And I want to be able to have as best the information as we can. And Dr. Laura Hawks, of course, at Medical College of Wisconsin is the main reason why, I've been involved in this and why I connected with Lisa. So I want to give a shout out to her as well. So with our newsletter from the very beginning of this happening, I think March 16th is still the day I remembered in my mind when the notice came when I was in prison and they shut down everything. It was volunteers could no longer come in, no more visits. And we just knew at that point there was going to be more coming, more restrictions coming. And I started to try and get information as best I could, but I was incarcerated. So there wasn't a lot of information I was getting that I could necessarily rely on. There was the news, but a lot of times the news, they tried to change your mind just with the headline. And I hate that. I never have been a fan of when I see a headline, you're trying to tell me this is awesome news. This is big. Don't do that. Just give me the information. You're right away making you not credible, in my opinion. But for many people, they fall into that trap. That's how the mind is. I fall into that trap sometimes too when I read stuff and I watch stuff like that. It's just the way it operates. So we tried to just provide information as best that we could with me and the few people that were working with the newsletter before I got out to give basics. And it's just been kind of that same theme that we continued on. And seeing early on, a lot of this was very predictable, right? The issues we were going to have with the vaccine, with people not trusting it. There's a long history of vaccine conspiracy theories or just lack of trust. And there's a lot of legitimacy behind that, as Mr. Wetzel says. So it's something that we just tried to get ahead of it, as the whole process was being built up, to say, this is kind of why this is going to be possible with the very fast process. This is kind of why there's unprecedented money and energy being put into this vaccine. And some people didn't grasp that. I had a conversation one time with a friend who was on the outside, actually, who said, more than cancer. I said, absolutely. There's more energy and money being put into this than anything else ever, I think, in the medical field. And so just trying to prepare people for that. And where we're at now is we have ambassadors all around the state. Almost every prison, we have one or two people that we rely on, who we've created a relationship with over time, that provide reliable information that's usually pretty sober. They're asking questions in a respectful way, or they're presenting issues that are going on there. And so we just kind of touch base with them whenever we need to know what's going on in the facility. And we'd actually like to further that relationship going forward to promote truth and facts, information about the COVID vaccine. I'm not big on pushing this as we want to give a tone of, this is why you should take it. Because even though that is the goal, of course, at the same time, we need to treat them as people, in the sense that we want them to make a decision. And you treat them as people while they're in, they can behave as people when they get out. That's a big theme of what an issue is, or times with recidivism and a lot of the biases that restrict us when we get out that are unnecessary, and where things are now. So we're just trying to provide them information, but we also want to provide them information in a way that makes them feel more comfortable with where the information is coming from. The information is the problem. Just like in the free world, the information isn't the issue. It's a matter of the trust with who's providing the information. So over time, we've made ourselves a pretty reliable source for information, with time after time being there for them in things where they can't get an answer from anybody else, or they're having headaches with the DOC or the social worker or general staff. So just trying to lean on that same trust that we've acquired, and respecting that, is where we are now. And trying to, in this packet of information we're going to be putting together, I kind of lay out reasons why, I think this is what Mr. Wetzel was referring to. If you eat hot dogs, if you get aspirin, if you have skincare, these are the same entities and organizations that are regulating the vaccines. It's not the same department necessarily, but it's all the same family that's overall seeing all this stuff. So there's a cognitive dissonance a lot of times that we think, okay, I'm not going to take this. Yeah, but you take all this. Just understand the lack of connection between things you do every day and how this fits right into that. And not telling them what to do, but just saying these are areas to be very aware of how your mind operates. And we've even had a personal development newsletter for a while where we talk about the way the mind works and how habits and framing and the way you can self-sabotage with little things every day. So just pointing out ways that maybe they're missing that allows them to think there's a really big problem with the vaccine. And then also acknowledging thoroughly, Dr. Hawks put together a very beautiful letter about how there's a long history of distrust from the medical community, and it's well earned. This isn't something that just popped up. This is not a new thing. It's just that we have this very pressing issue, and we're trying to address that now. But that should have been addressed in the back end. The ultimate way to solve this problem is to get a time machine and go back. And as Mr. Wetzel said, when I was inside, the DOC is terrible at relaying information. They expect you to just follow suit and not care why they're telling you what to do. But it's so simple just to tell us, why are we doing this? Just answer my question. I don't need a whole 10-minute meeting with you. I just need you to answer some questions about why we're doing this. And there has not been that in my experience where I was at in the prison system I was at. And I'm willing to bet the mass majority of other prison systems. And it takes, leaders to come in and change that. So this is kind of this overall way of addressing the best we can, honestly, getting people information so they can make the best decision for themselves, accepting and acknowledging that we don't know everything. We don't know the long-term effects, but we're very confident what we're seeing, and that there are a lot of highly educated, very rich people that are getting the vaccine as well. So if you're following trends and you're trying to pay attention to what's really going on and seeing the tea leaves, that tells you something as well. And not relying on celebrities so much to tell this story, but also people who've been fighting in this movement like people like Chazzy, people who are known to put their energy into this and have given their all. And there's more reliable than I think somebody who is in politics or somebody who is playing for the Bucks, for example. So it's just trying to find different ways to get that information to them so they make the best decision, but acknowledging the areas where they are very valid in doubting and having concerns, and hoping that through that a trust can be built and maintained, and they can have something to feel comfortable with the decision that they make.
So I'm going to ask you to expand on one part of that, and that is, we heard from Dr. LeMay and from the PADOC crew that a trusted member, right? So answering questions in a thoughtful way, using personalized experience, and having a trusted messenger. And it feels like, through what you're saying, like one amazing well of trusted messengers is people who have been incarcerated and are now back in the community, to reach back in and share information. And we heard from that Marshall report that I mentioned that people wanted their questions answered and wanted family and friends to tell them it was safe. And so it seems like you've really kind of hit the nail on the head in a lot of ways in this newsletter, and in the really amazing information you're sharing back in, which I hope maybe you'll show some examples of later, but which is different than what anything I've seen. So it's really not like anything that any of our academic centers are putting out. It's really boiled down, and you're really hitting like the very issues that incarcerated people are telling you they want to know about in a beautiful graphic way. And what I wonder is, you know, one thing that we think of urban jails and prisons, we also try to think of rural jails and prisons and what their means are. One thing that all communities have is, most communities have, is previously incarcerated people back in the community who could be reaching in. How does that happen? Like, how do you make that happen? And what are the some of the challenges, and what makes it work in your experience?
There's a couple of interesting points there. One is that I was a bit shocked when me and Dr. Hawk started looking around places, and I was reaching out to people I knew nationally involved in this, and we couldn't really find anything that had been done. I would have thought at this point, much more well-resourced, rich organizations and people would have put something together to go into the prison systems. And there are some small things we've seen, but they reminded me of early on, about 2 months ago, I was in on a meeting with the health clinics here in the DOC, and the DOC staff person said something like, "Oh, do you have some FAQs and like a little video we can include?" Like, no, you don't just use a well-worn, already existing concept to send this out. You have to develop something better if you're really trying to do this. Don't just do it just to say you did it and check a box off. Do it to have an effect. And so that's why we started trying to, working with Represent Justice. They have a really well done video. We're going to add to that, add some Wisconsin, Milwaukee flavor to it so that it has more of a connection. The ambassadors part you spoke about is huge. So we have relationships with the loved ones as well. Loved ones constantly connect with us. The stimulus check situation has been a big reason why I think we're able to have more of a reliability right now, because we were the main organization from the beginning saying this is wrong. You can file for your stimulus check. The IRS is full of crap. And so when it finally came, we got a lot of flack from that, from people that were incarcerated and family thinking that we were leading people astray. And so when the lawsuit came through, it was like, oh, you've been saying this the whole time. And then we started helping people file. And we've been dealing with that headache still with a very small staff. And it's an ongoing, constant headache. And so because nobody else is doing that, that allowed us to get a lot of connections with family members who are calling us and saying, how can I file? Can you help me file? So having the loved ones on board is huge. And I say that the formerly incarcerated being a part of this is big, but we can also lean on those inside who are leaders in their communities at every facility. And that's another avenue, is where you have 1, 2, 3, whatever, just really every reliable person you can find inside who has a connection, who people look up to, who people trust, have them help, share this information. And not just now, going forward, there should be always a system where every facility has a group of people that are shown to be reliable, shown to be level-headed and sober, and that have a connection with people, and that you have them inform people about what's going on, help them clarify things, meeting with the higher ups in the prison or DOC and saying, this is what we have going on, be completely transparent about things so that they can be completely transparent with them. That's the huge part of it. So it's not just us. I think it's more important than people that are in there right now that you connect with. But as far as those who are formerly incarcerated, I know it's touchy. Every facility is different. The entire time that we have been operating, I've had to try and find ways around the DOC construct to get information to people. That's why we started the newsletter to a large degree, is because information was not being provided in a way that it needed to be provided. And we just found an avenue with this newsletter. I will give them credit. They have not banned us. There have been times we've been critical, and they could have easily just shut us down a number of times, and they haven't. So I'll give them credit for that. But by and large, it's just a matter of we've had to find ways around them to get information inside, and they're becoming more warm to it. The current project where we're hoping to get their approval and their financial support to get this into all of our readers, which they requested at first. The issue that's right now might derail it is the fact that I'm currently on supervision. And so the organization, however, it's a nonprofit, it's an official 501c3, we have a board, I could be removed technically. My name is associated with the EIN. And so the laws in the state do not allow them to contract with somebody who's on supervision. But the best people who are doing this work in reentry, reform, abolition, whatever term you want to use, incarceration, are people who were in the system, who recently got out a lot of times. So you can't sincerely want to change things and try and better the way it is inside and better the way that people are not going to prison, all these different areas of reform, reentry, abolition work. I just use all the words because everybody has a different term they use for it. You can't really do that if you're not working with us. We were in there. We know it more than anybody. And we're coming out here getting paid pennies, if even paid at all, to keep fighting this system and trying to get information inside. So that's another problem, is like some of the rules need to be changed so that you can work with us. There shouldn't be that barrier. So this, we're hoping, but every state is different, and that's the experience we've had and we're having right now. And we're hoping that it comes all together pretty effectively so that we can continue to effectively get this information into people inside from the standpoint that we have that experience and we know and we really care to give you the unbiased info that you can make a decision on your own. We don't want to tell you what to think. We just want you to be able to think.
Yeah, thank you for that. And what I'm hearing you say, like, if I'm hearing you correctly, is for this pandemic and for future pandemics or natural disasters, whatever it is, anything where like information needs to get out there and get out there quickly, perhaps part of real, true pandemic preparedness for correctional facilities is having trusted, identified leaders amongst incarcerated people to quickly and effectively push messages out and to kind of parlay back into the outside with trusted people in the community. So I think that gives us a lot to think through. And I know that it's generating a lot of chat here that we'll bring back to you after. But thank you, Shannon. I'm going to move on to our next speaker now. So next we are going to hear from Chastity Bowman. She is the president and founder of Opportunities People's Justice Leaders, formerly Ohio Prisoners Justice League. She has been a criminal justice reform advocate for 5 years and is the newly appointed chair of the Prison Committee for the NAACP Cincinnati chapter. She is currently a part of the 2021 Just Leadership USA Leading with Conviction cohort and is the 2021 recipient of the Faith Leader of the Year by the organization Faith in Public Life. She is the proud wife of Rufus Bowman, who is currently incarcerated in Ohio's prison system. She will speak to us about grassroots organizing around COVID-19 within prisons and jails and the role of family members in COVID-19 education. So, Chastity, what efforts has your organization been doing surrounding COVID-19 vaccinations for incarcerated people in Ohio? And what do you see as the role of family members of incarcerated individuals in vaccine education?
Yes, good morning, well, afternoon, everybody. It is a pleasure to be on this panel with some amazing people and to hear everyone so far. It's really kind of uplifting in a time where everything seems kind of bleak and like we're not seeing any movement. And so it's really uplifting to see the work that folks are doing, to hear from Secretary Wetzel. I'm glad to see you again. I met him in 2018. We were doing a lobby day for Unlock Higher Education. So that was, it's great to see you again. So what our organization does, we cater to all 28 facilities across the state of Ohio. We have currently over 400 men and women that we communicate with via JPay, our emailing system through the prison. And then we have over 1,000 family members within inside of our group that we filter viable information to concerning their loved ones, whether that be a complaint of the conditions in prisons, or if they just have questions about issues such as this, you know, the COVID-19 vaccination, which is a hot item in between the stimulus and COVID-19 vaccination. This seems to be what our center of focus is. So what we try to do is partake in conversations like this and speak their truth and ask the questions that a lot of people don't want to ask, the hard questions, you know, and have the hard conversations that are ailing families and those that are incarcerated. What I'm hearing in Ohio from inside, from those that are incarcerated, is they have the mentality of, we would rather take our chances with the virus than we will with the vaccination. And that is solely because there isn't enough education around it. We are fighting to make sure that this is an optional, it's optional thing. Like it's not a mandatory situation to where they have to take it. If they don't take it, they'll be reprimanded, or you know, and not feel alienated or dehumanized because they don't take it. And that's some of the complaints that we've had, you know, the frustration that comes from staff. Well, if you don't take it, and you're going to be sick, and we're all going to be sick. But I think the problem with all of this is, when they watch the news and they see what's happening in the news and the uncertainty that we have on the outside, it gives them that much more uncertainty. And so I just had a talk with my husband this morning, and I said, I really want to know how you feel. You know, I really want to know what you're feeling concerning this, just to try to fix my head into a space to where I could really feel what he's feeling and the others are feeling in the population. And his words were, we have correctional officers that tell us on a daily basis that they will refuse to take this. So what makes us feel like we should take it? Why should we trust it? And that is the culture across the country. I talked to several different other national grassroots organizers, and that is the culture. That is what we're hearing across the country. And so, not to continue to echo what everybody's saying about the trust mechanism, but what we're doing as an organization, we are just trying to filter out information, as much information as we possibly can, whether you're in support of it or you're not. We try to let them know the importance of why you should take it, and then let them know it's okay if you feel like you don't want to take it. My husband has a peer-led program called Stay Focused Movement. In the facilities that he's in, there's approximately about 102 men that are that partake in that program. So I'm constantly sending information to him and allowing him to filter that information to these men in the facility, to be that voice of reasoning, to say, you know, okay, this may not be something that I feel like I support, but here's information to help you with that, you know. And I think if we had more people like the people that are here now to come to us on a smaller scale and help us speak to these families, because we cannot, well, I'm not going to say we cannot trust that the state is being totally forthcoming, but a large portion of people do not have trust in the state. They have more trust in grassroots organizers like myself and Shannon. They have more trust in each other, you know. So if we had more of Dr. Rupali's, if we had more, if we could see, if Ohio could just implement some of the things that Pennsylvania is doing, that all in itself, you know, could really help us in the efforts to be able to allow people to make the decision that they need to make concerning this vaccination. But right now, people are just afraid. There's not enough information about it. And especially going into the facilities, it's a one-sided biased view that they receive. And it's like they get a notice that goes across the screen that says, you know, we'll give you $5 if you take this vaccination. And then they do it. And then the $5 is taken because they owe fines or fees. So it's like the incentive program isn't very promising. So there's another letdown. They've been let down in that aspect of it. And then they're seeing people that are taking that have taken the vaccination and they're getting sick. So that opposes fear, because again, there's no education there to say, okay, this is what happens after your first dose. This is what happens after your second dose. They don't have that information the way that we do, the way that we see it. And so it's very complicated when you're trying to give that type of information to people who they refuse just to do it because they are afraid, of what could possibly happen. And then with healthcare being so poor inside of our facilities, it's like, if I get sick from taking it and I have a reaction, how fast will somebody come to me? How quickly will I get aid? Will I get aid? Will I die from this? So there's so many elements to why people feel that they shouldn't do this, as opposed to why they should. And I think that if we could just get in spaces to where we could amplify why this could be a positive thing, or just give more information concerning it, I think we would see better results.
Thank you for that. I'm going to stop that one there, and we'll move on to our last speaker and then come back to a bunch of questions that are being generated. So next and last, we will hear from Elizabeth Matos, who is the Executive Director of Prisoners Legal Services in Massachusetts. Elizabeth was a staff attorney with the organization for over 7 years and a law student supervisor, which she has continued to do as director. She has been involved in litigation about solitary confinement practices regarding incarcerated people with mental illness, guard on prisoner assaults, and lowering exorbitant prison phone rates. She also helps coordinate 2 prison reform coalitions and advocates with the state legislature on the organization's legislative priorities. Prior to practicing prisoners' legal rights law, Elizabeth practiced housing, education, disability, and immigration law at South Coastal County's Legal Services. Preceding her legal career, she was a Fulbright Scholar in Mozambique and worked as the Gender Outreach Coordinator for the U.S. Embassy in Maputo, and served as the Immigration Rights Coordinator for the Massachusetts Immigration and Refugee Advocacy Coalition. She is a graduate of Brown University and Georgetown Law School, and she will be speaking to us a bit about legal considerations of COVID-19 vaccination and vaccine behavior within the larger context of decarceration. So Elizabeth, we are so excited to have you. Help us understand what some of the legal arguments around vaccine mandates are for both incarcerated individuals and correctional staff. There has been a lot of talk about that, but how can we think of the legal arguments surrounding those things? And then, how do we place current COVID-19 vaccine efforts among incarcerated individuals and staff within a larger picture of criminal legal reform?
Thank you, Lisa, and thanks everybody for having me. And sorry you got such a long bio. I'll have to look at that. But I'm really honored to be here and speaking with this amazing panel. I just wanted to start out by giving some more information about Massachusetts, because that's where we're based. Not every state has a legal services organization that does advocacy on behalf of incarcerated people. And so I wanted to talk about that a little bit, because we do impact litigation, direct advocacy, and also policy work, like you said. And of course, during COVID, the bulk of our work has been around decarceration, and vaccination has been a big part of that. Right now, their officers are not being legally mandated to get vaccinated, and prisoners are not either. However, there are a lot of issues around incentivizing people, and that's already been an issue here in Massachusetts. Just to give you some basic stats, right now it looks like we're slightly under 70% of the state population. So there's about 13,000 people incarcerated in Massachusetts right now in the county system and the state system combined. And like other states, the incarcerated population has gone down in recent years, but also in the last year because of jury trials and things like that not happening, and less people being admitted generally. But still, so it's a little under 70% of the state population for folks who are incarcerated, just a little over 50% right now of correctional officers in the state population. So it's significantly lower for correctional officers, which other people have mentioned is a trend across the country. And then for our county jails, where in Massachusetts a little bit different, it's people who are serving 2.5 years or less are in the county system. There are actually more people in the county system, and like other places, mostly pretrial, so not convicted, but it's around 40% there, and slightly lower, although the numbers seem to be going up for staff. In Massachusetts, they have said, or I think this is across the country, that you can mandate vaccination for employment, but that has not happened. The DOC has, the Mass Sheriff's Association have elected not to do that. And for the incarcerated population, we had this interesting situation where the commissioner said that she was going to give people extra good time if they were to take the vaccine, which I think is problematic on a number of levels, but still was a policy that was being put out. And then the Boston Globe did a really sensational article, and the title was, people that prisoners were going to get out because they were getting good time for taking the vaccine. And the governor rescinded the policy, but that didn't get communicated to people inside. So people were getting vaccinated thinking they were getting the good time, and then of course didn't get the good time. So kind of similar to what Chastity was saying, here's what we're going to do for you, and then that falls through for whatever reasons. And so it just adds to the layers of distrust. And I think it's worth mentioning that Massachusetts prioritized vaccination. So for people in congregate settings, but including staff and people incarcerated. So they were in the first phase of the vaccination rollout. And I think there may be different reasons for that. But one reason that at least some correctional administrators stated was because we had active litigation going on COVID and decarceration. And that the hope was that the vaccinations would really kind of quell the litigation, so that that would go away, and the focus would be on how vaccinations would improve the outbreaks going on in prisons and jails across the state. Echoing what others have said, there's been definitely a lack of communication, but early on, I will say that the Executive Office of Public Safety reached out to us and to some grassroots leaders. There's an organization we work closely with called Families for Justice is Healing, and the National Council of Women and Girls. And we were kind of all on a call together with a number of people trying to figure out how to get information to folks inside. But there was a real push and pull in terms of what information and how the information would get distributed, and kind of echoing a lot of what Shannon said, just this real unwillingness to recognize the legitimacy behind the distrust, that it's not just ignorance and people not having the information. People are actually somewhat well informed, and that the distrust issues are based on real experiences that people have had, but that there wasn't really a willingness to recognize that in the educational materials being provided. Ultimately, I did participate in kind of a video production that was done for people in the state system in the county jails. But we and this is one difference from what Dr. Rapali was saying, Dr. LeMay, we, as lawyers, I don't feel like we're in a position to say, here's sorry, my light just went off. Here's my personal experiences, what I'm personally deciding to do for myself. As lawyers, our feeling was very much that our job is to provide the information so that people can make an informed decision for themselves, and not tell people I personally am getting the vaccine or any of that. And so that's been our internal policy here, is not to do that. And so we did participate in this video, and the video was me basically saying, we're not here to tell you to take the vaccine. we're here to tell you, we'll give you as much information as we can, and that we understand that things are difficult. Our hope is that, you know, eventually conditions would improve as a result of vaccinations, but that we're kind of there for support mostly. But like other people have been saying, and people really haven't had, so some people, depending on what facility they're in, some people have had the experience of being able to talk to nurses and doctors about their questions before getting vaccinated. But it seems like the large majority literally sat down, had consent forms to go through, signed, and got jabbed. I mean, that was the process throughout a lot of the correctional system. And so it's not really that surprising that people would be hesitant to get vaccinated. And so, like, for example, we have a client who his questions were around allergies, a ton of medical allergies, and was asking, what's the protocol if I have an allergic reaction to the vaccine? And he never got an answer to that, but his mom is a nurse and she said, you should really take it. So she was giving him that information. You know, you've been in there for a long time. He's a lifer. You know, they know you have allergies, you've got the EpiPen and all of that. So he went in, he had an immediate allergic reaction to the vaccine. He swelled up significantly, could not actually breathe. He's listening to the nurses have a conversation about whether or not they should call an ambulance, and he's trying to tell them to get the EpiPen. They don't get the EpiPen. Eventually they get Benadryl and get it down his throat and he recovers. But there are other people watching this, right? There are other people watching this. They did not clearly have a protocol in place. It was a bad example, but unfortunately those things happen. And that was, and that's just, I want to highlight that as an example of one other thing that I don't think has gotten as much attention today. And that's the fact that, you know, out here, we can talk to our provider, we can pick a pharmacy. There is one medical provider inside that so many people who are incarcerated have had really negative experiences with. Not everybody, of course, and some people get decent care, but it doesn't take much Googling to see that prison healthcare is really problematic for a whole bunch of reasons. And if people have gotten have gotten bad care or inadequate care, or even been harmed, many people permanently, by the kind of medical treatment that they've gotten, not to mention the health equity issues that are exacerbated in the correctional system as well. That is a huge layer of distrust that is added on to all the other kinds of distrust we've already talked about, because that's the only person you're going to. That one person who may be giving you the vaccine may be the nurse who decided to deny you medical care after you were assaulted by a correctional officer because she knows the correctional officer. So these are things that also happen in the prison context that I don't think were really given enough credence. And so I agree. I think there's really been a lack of kind of one-on-one communication with people and listening to learn versus listening to convince, which is something that was mentioned before. And so I think that's still a reason why the numbers are so low in a lot of the counties, because there hasn't been that process. Also the culture of COs telling people that they're not taking the vaccine, or even telling them you shouldn't take the vaccine. That's something that we've also heard. In correctional officers not wearing masks. So people really kind of perpetuating the idea that it's not a big deal. When of course, I think a lot of people who may not have taken the vaccine out here have taken it inside because they've seen so many of their their comrades and fellow cellmates fall ill or be on ventilators or die as a result of the virus, and for that reason have decided to take the vaccine. So those are just some of the things that I wanted to mention. In terms of legalities, I think what we're going to see, and I'm very interested actually to hear more from the Pennsylvania folks on this, is, how are we going, for people, obviously people have agency to refuse the vaccine. That's happening, both correctional staff and for folks incarcerated. And we're already seeing, who will have access to family visitation, which is huge, right? People's mental health has really deteriorated over the course of COVID because they've had so little family contact. And so now to be separating those who have gotten vaccinated versus those who haven't in kind of using things that are considered benefits of the correctional system, but also positively correlated with a successful reentry and lower recidivism rates, I think we really have to be careful about how we're doing that, because there may be unintended consequences, and also maybe not the right incentives for getting people to get vaccinated. So I'm interested in hearing more about that.
Yeah, thank you. And you know what? You're a mind reader, because that was the first question that we've collated from putting together all different questions in the chat. So you felt the energy just flew through you, and you knew that that's what people wanted to know. So let's dig real deep on that one, because I think it's a great question and something that probably everyone on this panel has something to input on. So I'll let people kind of unmute themselves in turn, but I think that that's the real question. So there may be some benefit, or in some systems, different incentives are being tried. We have heard about giving good time in other systems as well, not just Massachusetts, as well as cash incentives. The CDC just came out in the last week really and changed sort of guidance around what vaccinated people can do. So in the community now, if you're vaccinated, you can hang out in a small group, and you can hang out with other vaccinated people, and you can be with one family who's not vaccinated, right? So opportunities are expanding for all of us who have felt our mental health pushed to the brink, right? And this plays out differently in correctional systems. So when you get to unintended consequences, let's think it through a little. What if an incentive is, if you get vaccinated, you can have family visits again? Or if you and your family are vaccinated, you can visit again, which we know is good for everybody, right? That part's not up for debate. But we wonder, what if that impacts people disparately, right? So what if white people then have more access to vaccines in the community, and less distrust perhaps historically, and get higher vaccination rates, and therefore can have visitation with family more? How do we think that through and prevent around, some of those unwanted side effects of what may be at least a scientifically founded incentive? Maybe we'll start first with Dr. LeMay and then go over to Pennsylvania.
Sure. No, it's a great question. And one thing I think many of us that work in this space have looked at, what if we provide incentives? I think a couple of months ago, Dollar General and a couple of the other grocery stores mentioned that they would pay their employees to get the vaccine. I, as a public health person, have a strong aversion to incentives because I think it breeds inequity. I think it has to be, if you provide an incentive to get a vaccine, you're essentially also lowering trust in the healthcare system. You're essentially saying implicitly that we're going to pay you, we're going to give you some sort of a benefit of getting the vaccine, and therefore your motivation for getting the vaccine is not because it's going to protect you, it's because you're getting this additional, motivation or benefit. And so I think, my bioethicist colleagues that work with me on these issues, we kind of get into arguments all the time about this. And my concern is always that it can't be seen as coercive. And so I think the rule here, regardless if people are considering this idea of any sort of a mandate, is what is seen as coercive? Are we essentially leveraging and sort of, I think, stepping on brown and black bodies, if I can say that, to get people vaccinated? And that's where I have really, really strong opinions and concerns about this. And I don't recommend mandates for that reason. If I put on my public health hat and talk about population immunity, we of course want to get as many people vaccinated as possible. That gets us closer to herd immunity more quickly. But I think what you end up doing, or what you end up sacrificing to get there, I think is more concerning to me than sort of the near-term benefit of getting population immunity.
Okay, so I hear you saying that incentives, especially financial incentives, can breed further distrust, because you're basically saying, okay, you don't trust the health system, but maybe with some money you'll trust the health system. Am I understanding?
Right, and no, that's right, Lisa. I'm sorry. It also leads to more inequity. We have seen that in other places where when we ask, for example, healthcare workers to get a vaccine, the flu vaccine is one perfect example. We know that really causes, I think, not only distrust in the employer, but it also causes inequity, because again, who has access to a vaccine? Who is a person that says, you know what, $15 for me goes a really long way, so I'm going to get the vaccine? And to me, it's just a very challenging, it's hard to gain that trust back is really my issue.
Great, thank you. I'm going to turn it over to Secretary Wetzel and Dr. Conti. What do you think about visitation and its use as an incentive?
Yeah, well, I think it's important, and since we're at Yale, I think we can have nuanced conversations. And I think it's important to understand that anybody who's like operating in this, and I know some of the doctors, you're actually working and doing this, there's no absolutes at this point. And right now, our focus is to keep as many people alive and healthy as possible. So I think you got to think of this in phases. And right now, we're in a phase where we're trying to get as many people vaccinated as possible, and we have limited movement. But one of the things we just talked about this morning with my team is we have a bunch of folks let's say we have a facility with an outbreak and they've recovered. And so we have a large group who's in recovery. I asked my team today, how do we justify quarantining people who are in recovery and we know they're not at risk? So I think it's really, as we evolve, I see this in phases. I see the first phase being, let's figure out how the hell to get as many people vaccinated as possible. And my theme throughout this is both and. Whatever it takes. Like, I agree. Listen, I'm uncomfortable with a lot of this, but we're not living in an ideal world. Like, we're living in a world where people are dying from this disease, right? And I will tell you, the operators like me, we feel a lot of responsibility in general, and a lot of times we don't have control over conditions. We don't have control over who's coming and going. So right now, let's get everybody vaccinated as soon as possible. Once we get through vaccinations, as you point out, CDC put out guidelines. So the question is, I'm sure some folks are tired of wearing masks, right? So I'm sure that, folks who are vaccinated, once they're vaccinated, we're going to have an issue with saying, why do I have to wear a mask if I've done that? So these are going to have to be nuanced decisions. And I think that this phase is the vaccine phase, and the goal is to get as many people, and we use a cohort system here, so increasing out of cell time, increasing visits, and those kinds of things. But right now, every default is what is the best thing to do medically to meet this goal of having less people die and having less people get the disease and less outbreaks. And that's it right now. And then once we get vaccinated, then we have these decisions to make. But it's hard for a guy like me to look beyond, like, what are we at today? What's our numbers today? How are we going to increase vaccinations? What can we do better, and what works? And I think the other thing is different stuff works for different people. So I think, and one of the approaches we took is be creative. Like, we encourage our facility, be creative. Ask, like, we try this groundbreaking thing where we ask people who are affected by something what they think about it. We don't do it great, but we're really trying to become an agency that just asks, and then we try to work it out if we can. But I think there has to be nuance, and it has to be individualized, and we really got to be conscious about unintended consequences, because this to me feels like a lifeboat exercise every day, and you got decisions here, and I think the best illustration is like transfers, right? Say our population went down 7,300, and you say, transfers are dangerous, 100%. But our population didn't go, we have 25 prisons. You don't divide 7,300 by 25 prisons and we get an equal population reduction, right? The other nuance is that we have some facilities with newer designs that we have a history that we can control outbreaks to one housing unit because of the physical plant and these kinds of things. We have other prisons that are older, bars, dorms. And so it's an absolute fact that if we want to have less people die and less people get the disease, we have to depopulate older prisons at a faster pace than newer prisons because we can control the spread. You can't do that without transferring people, right? So that's one of these illustrations why I think it's more about the process, and it's more about having the right people in the room and making a decision and then understanding the implications. And then this is where Doc comes in. Like, we just I would tell you early on, like, I'd meet with the entire leadership team and I'd go, look, this is what we know today. I'm sorry. We could be changing everything tomorrow. That's the nature of this. And I would also suggest that the gaping hole in this entire thing, from my perspective, is a specific information about correction specific from the feds to corrections. And we've worked with so many people, and I appreciate our partnership with Yale. And, you know, some of you, I'm blowing up Emily's phone, like, connect me to this person and that person. But if we're looking back on this, we need, when something of this nature that's going to have a disproportionate effect on corrections, it needs a separate effort. And I would say that I've had a bunch of conversations with the Biden administration about that very thing. Like, let's really, like a clearinghouse, for instance. One of the things we've been pushing, CLA, other organizations, how about a clearinghouse of information from the feds specifically for corrections? You talk about products and this and that. Part of me, it kind of bums me out that everybody's doing all this great efforts. Man, it could be easier if we were all like sitting around this big table, like trying to figure out what the best way to do stuff is. And I think the lack of federal leadership early was a real hurt piece on this. So I just want to say, I'm just trying to provide context that it's not either or. It's not real simple. You're not sitting like on a Zoom trying to make a decision. Real people, and you know, I don't believe in forcing anybody to do anything. Like, this is a health choice that people should make. But there's also people who are not vaccinated in a congregate setting are more likely to spread a disease. So that's what I'm saying. There's a tension. So if we're going to make a decision, conscious decision, understand what the implications are, and be cognizant of disparities of race because of decisions we made. And that's what the criminal justice system has never done. Conscious decisions, understanding the implications, and making a choice. Sorry for going long, but I felt like the context was important.
No, I think it's critical, and yes, urgent, and every day is changing. So we totally gather that from you and agree. I wonder if you guys have specifically thought through visitation, you know, and how you will open it again, and how that links to vaccines, if at all. You may not have been able to get there yet. Just wondering.
Well, our plan from the beginning was, so we did Zoom visits. We have Zoom visits at every facility. We propped that up day one because we felt like that communications to family, adding separation from family to everything else, all the unknowns around COVID. I mean, I think for us, probably when it got real for the population is when the NBA, NCAA tournament started canceling. Like, that's the signal. Everybody's like, oh, whoa, this is real. Wait a second. What do you mean we may not have an NFL season? Like, it sounds funny, but and Ross will tell you, like, sports, oh my God, like being locked up without sports, I couldn't imagine working or living in that environment. So it got real at that point, right? And so we did visits, and now we have video visits. We're working so they have them accessed on every housing unit. But I think face-to-face visits are important. So what I'm guessing is once we get facilities fully vaccinated, whatever we end up defining that, because we've heard all kinds of stuff from all kinds of experts at where you achieve herd immunity and those kinds of things. So we'll likely get vaccinated, wait a little bit to see the outbreaks go down or other things going down, and then come up with a strategy for visits. And certainly vaccines are going to have to be part of it. I mean, there's just no ifs, ands, or buts about it. Because again, outbreak, you think of the cost, the human cost, and those kinds of things. But we haven't made a firm decision yet. But we're anticipating, like, 2 weeks after all the facilities get vaccinated, whatever our strategy is going to be, it'll be at that point. With input, obviously.
Got it. Thank you. I'm going to go to Elizabeth Matos, who has her hand up, and then to Shannon.
Yeah, I mean, I was just wondering, kind of along the lines of the clearinghouse, you know, obviously there's been a lot of talk around decarceration and COVID, but there's also been, I mean, to me, it seems like an unprecedented interest from the public health and medical community in prison conditions, and how they've always pretty much been antithetical to public health, and especially because of the overcrowding, but not only because of that. And if that is also, you know, I think it's being perceived as sort of this dichotomy between activists and folks on the ground pushing for decarceration, and correctional staff and administrators sort of opposing that. But I'm not sure if that's true. And I wonder if that is part of the conversation from the perspective of the correctional administrators on the panel. That depopulating not just sort of the older facilities, but depopulating generally as a strategy to prevent this kind of devastating consequence in the future, but also just as a general harm reduction measure.
I guess any question referred to a correctional administrator is mine. Is that the rules of engagement here?
Well, other people have info from correctional administrators, but we're sorry to put you on the spot.
That's okay. I've spent 11 years on the spot. I suspect I'll be on the spot slightly longer. Could you just boil it down to the main question again, please? I was too busy thinking up jokes.
Do you see decarceration as a realistic strategy from?
100%. And I think two things. And I think the first thing talking about the need for decarceration. Over my 10 plus years here, our population's down about 12,000. It was 51.7 at the peak. I think we're down to 38,000 now. 7,300 of that 12,000 happened over the past year. And I will tell you that in the beginning, we came up with a bunch of strategies. Pennsylvania does not have discretionary release. The governor kind of pushed the envelope a little bit, doing a reprieve, but really didn't get much of that. But 7,000 inmates less, and I would tell you that I wish we were down another 2,000, and I feel like we'd be in a better place. I would also tell you that, to be completely transparent, we've seen increase in violence in Philadelphia, but otherwise, we've seen a reduction or at least a flattening of crime. We haven't seen a crime spike other than violence in Philly. So I would make the argument, and there's no increase in violence in Philly from people coming out of prison. So I just want to say that we looked at that. So I would argue that what we've learned is that we've seen the nation decarcerate larger than ever. And you can make an argument that a bunch of the effort now should shift to maintaining those gains and figuring out how to kind of make that the new normal and a reset. So yeah, I think population reduction is relevant, and I think one of the things I was warning my team today, if we have every person, every staff member, every incarcerated individual vaccinated, that doesn't mean we're not going to still have outbreaks and we're not going to still have people getting sick and this and that. So vaccines don't make that go away. Social distancing, having space, not having crowded prisons, it's a real thing. And we're talking about a system. We went into COVID at 97% of our operational capacity and 99% of our staff positions filled. We are an outlier and just got really lucky. Our POP went down, so we were at 97% of capacity. Our POP went down by 7,000, and I'm sitting here telling you with a straight face, we still need a little room, and if we're in a new era where pandemics are going to become a thing, what we used to assume as a capacity is not the same capacity. Now, the other caveat I'll say is, single selling across the board gives me heartburn. A lot of our completed suicides occur in single cell. So when you think about unintended consequences, it's like you make a policy to make people safe for COVID. Let's make sure we're not creating a situation with mental health because of isolation and those kinds of things. But yeah, I think no one who's operating a facility would say, "Oh no, we want to pack them back in." They're much easier to manage when there's more people. No, not at all. We need to use this as an opportunity to say, okay, we have overused incarceration. If this isn't a proof of concept, I don't know what the hell is, right?
Thank you for that. I'm going to go back to the visitation because I also want to let Shannon have an opportunity to respond to that, and Chastity as well. Shannon?
Yeah, I don't know if I have a comment about the visitation specifically. I had some other comments. Can I?
Yeah, please.
So one thing I wanted to say is that the reason I was laughing when John said about the sports, because that's exactly when I remember when I was inside, when I started out the news, it was like, oh, this crap is real. That's exactly how it was. It's kind of funny. So the incentive concept is really interesting for me because I spent a lot of time inside trying to get people who are incarcerated allowed to donate their kidneys. And a big part of what we ran into was the medical community didn't want that. That was the biggest headache we've had in Wisconsin, at least, because the main outfit that controls that is the UW Wisconsin, their organ and donation procurement department. And so the ability, coercion concept came in a lot about how we're in this setting where we're not really voluntarily freely having a choice, a decision in this regard. And I found that belittling and also ridiculous, because we are allowed to make decisions all the time. In the legal system, they don't say that our pleas weren't allowed. You know, all these things that are voluntarily and freely given, but I want to donate my kidney and I can't. And so when I thought more about it, I said, if I want to save somebody's life, or if I have a family member who is dying, how is that not an incentive? How is that not a powerful motivation just as well as $20 is? So it's a matter of, everything in life is already incentivized. Everything we're doing, talking about today to try and get people to increase the uptake of vaccines, this is all, how do we incentivize people? But if we offer them $20, suddenly it's a different thing. So it's not a matter of the incentive, it's a matter of where does it get funny? Where is it problematic? And that's a conversation, like you said, Janet, is there are no absolutes, definitely. I fully agree with that, and that this is a very tricky thing when you're inside. You're trying to save lives, you're trying to reduce the prison population, you're trying to deal with a lot of people that are yelling at you about different things. So it's not a simple thing. I think one clear cutoff is giving people release because they take it. That is utterly ridiculous, in my opinion. You should just be releasing people because they shouldn't be in prison. If you can release them because they take the COVID vaccine, you can release them without the COVID vaccine. So that's just beyond ridiculous. But the money concept, you know, I don't know. I'd be very curious to see down the road if that actually does benefit uptake, if that actually does benefit trust, because down the road, will it be, okay, we have something else we want you to do now. You expect me to, you know, are we going to get paid for that as well? Are you providing information because it's for our best interest or because it's for your interest? You paid last time, you don't this time. Maybe last time it was only because it was your, it's just all these tricky things coming down the road. Like maybe you're not setting up a good grounding for a long-term relationship that is needed to have these type of problems not be where they are right now in the future. So I don't know, this is just kind of the questions that I think about that. And in terms of the visitation, I mean, that's the big thing here in Wisconsin, is that people realize, you don't even need to tell them, they realize that if they start taking the vaccine, if there is more of a herd immunity that is acquired, things are going to get back to normal. People can go back to the work release jobs, they can see their family members. So that's just a given. There's a fear here in Wisconsin that because they've allowed us to have video visits through Zoom, that will be the way that it goes going forward, and they won't go back to physical. I don't believe that, and we're trying to get a clear answer from the DOC about that right now. But you know, having some clarification there would be very helpful for the population of Wisconsin, I know. So those are just some of the thoughts that I had on that topic when we were talking about it.
Thank you. Chastity, I know that you wanted to join in as well.
Yeah, so I want to speak to a couple of things too, really quickly. So decarceration is absolutely the answer. So in 2020, when we began pushing this fight for COVID-19 in the facilities, Ohio's 2019 annual report told us that 15,000 people were at risk for adverse reactions to COVID-19, that they were that population of people who had the underlying conditions. And so we did a campaign starting in April, and we asked for 20,000 people by May. So where did the 20,000 come from? Well, we wanted the 15,000 people who were immunocompromised, that the annual report clearly said were. And we were asking that they be released, and they were elderly. You know, they were elderly people who only had 2 years or less left on their sentences. And we were pushing that, you know, we were pushing for that population of people to bring down the census in the prisons. Our organization alone in 2020 were able to put 1,500 medical reprieves in families' hands, and they went to the governor's desk. Unfortunately, the governor gave the responsibility of those decisions to the parole board, and we know that the parole board is not very favorable in releases. And so we haven't seen that many releases in Ohio due to COVID-19. And a lot of the stigma that I didn't mention earlier is everybody hasn't even been tested to know who's positive and who isn't. And so the question that the men and women are asking is, okay, we can't even get a COVID-19 test, but you want us to you want to pay us $10 to get a vaccination? Like, it doesn't make it make sense, you know, make it actually speak to the issue and the problem. Are we really trying to fix the problem, or are we trying to cover a problem? What is it exactly that we're trying to do here? Because I know that a couple of months ago, it went from no mass testing or trace testing to we're going to test the wastewater in every facility. But what really does that give us? Does that really tell us how prevalent this virus is in each facility? And now we're at the stages of visitation. You're absolutely right. We need that human contact. These men and women need that. Mentally, they need that. However, you are inviting in the public who isn't, or they may be vaccinated, who may or may not be asymptomatic, who may or may not have had COVID. And now you're inviting them into the prison, which, yes, we know we need that human contact, and I'm all for it. I haven't seen my husband in over a year, almost 2. But are we really taking the proper safety measures to make sure everybody is safe? Because here's one thing that I will say over and over again. As long as there's COVID in our prisons, there will always be COVID in our society. So are we really taking the proactive, effective approaches that we need inside of these facilities to make sure that everyone is well? Because we obviously didn't take those approaches to make sure that they didn't contract the virus, because they were already in a quarantine state, right? So we really didn't know much about it then. We really don't know much about the vaccination now. So how are we really going to attack this issue and not do surface fixes? How do we really attack this issue and make sure that people are getting proper health care to make sure that they are taken care of and not sitting in a cell for 14 days without any medical care? That's the truth. So when are we going to speak the truth on how these are happening? Yes, the incentive sounds great. Yes, it sounds wonderful to give this education, but are we really going to get down to the nitty-gritty and say we're holding our nurses accountable for not giving proper health care when they have a oath that they should uphold to give proper health care to these people? Are we going to hold the state accountable for not making sure that men and women are getting tested, simple testing? And it's very hard to speak to a population of 50,000 in Ohio when they see on TV that everybody in the state is allowed a test, and they can't even get a test, but you want us to take a vaccination. And so we just have to really kind of figure out, what are we speaking to here? Are we speaking to the problem as a whole and trying to fix it as a whole? Or are we just using certain aspects of it to speak to? Because we know that COVID is going to be around for a while. It's not going away anytime soon. But to the incarcerated population, it makes it a little more stressful and complicated because they do not have access like we do to a lot of things. So that's just speaking to all of that.
No,
Can I respond?
Yeah, please.
Lisa, can I just respond? First of all, Chastity, you really need to copyright, like make it make sense, because I already stole it. I told Conti, write that down. Because listen, I think that's the takeaway from this. Like, freaking make it make sense, even in the community. Like, make it make sense. Have it pass the smell test. But let me just mention about the sewage testing, because I really do think it's an important part of the context. And let me tell you how we use it. It's not in lieu of testing individuals who are either symptomatic or mass testing when it makes sense to do that. But it gives us a baseline, and it gives us, at a glance, a look at how much COVID is likely in that facility. And we actually have a formula where if we have a sewage level at, let's just say B, whatever it is, we can actually generally predict within a couple percentage points what percentage of the population, if mass tested, will test positive. So I don't think it's an either or, but I also think that as we open up, a big part of systems that are going to be effective are going to be agile. And so you really need all this information. And Emily will tell you, her team and I met with our team, and what we're really trying to do is get enough tools so we can get the information and make objective decisions. And so if you have a place, I'll tell you, my guess would be in August, if I have a place where the sewage detection says no detect, where I don't have, maybe a couple asymptomatics, but I don't have a large number of people, I have no indicators, I'll be more likely to feel comfortable with face-to-face visits with those checks and balances in place. Because the last thing we want is to open up and then have to close down again. And Ross will tell you that I couldn't even imagine what that would look like. Like, I couldn't imagine after a year and a half, and I will tell you that I've never been prouder of our staff and our population. I mean, all of them, I think, are just doing what we need them to do, right? I couldn't imagine finally saying, all right, thank you. You've done everything we've asked you to do. We're opening up. And then we have to lock down again. So I will tell you in Pennsylvania, we're going to move slow. I do not want to set people up for that level of disappointment. But the reality is we have all these smart people around. Nobody knows what's going to look like. You know what I mean? So we do have to proceed with caution. But again, I'm going to push process, making sure we got all the voices around the table and just do the best thing.
Thank you so much. I want to ask a little bit of a provocative question just to keep the spicy conversation going. And maybe Elizabeth could speak to this first, but please jump in. So we've heard some about what are some maybe promising strategies, communication strategies, engagement, education, trusted messengers, all of that. Let's talk a little bit. I mean, I'm imagining there are correctional systems on the line watching this, and some have other ideas that they've been trying, right? What are the things that have not worked that you've tried, or what are the things that we think cross the line in terms of the rights of people who are incarcerated? Like where do we take it that it just goes a step too far?
Well, I think I actually want to give some credit to the Massachusetts system. They reached out not only to us, but to grassroots folks to say, can we work on a video together? They recognize that you're more trusted messengers than we are, even though we were in active litigation. And so I think that is really commendable on their part. And there was some collaboration there. In addition to the videos, I know there's a lot of written materials provided, but also in different languages and all of that. And it was, there was a major effort to also be inclusive in terms of diversity and include formerly incarcerated people in the messaging and in the videos. So I think that was helpful. I think for the counties and in the DOC too, it really does seem like it's dependent on what facility you're in and maybe on the leadership of medical staff. So I still feel like if the Department of Public Health had been involved in vaccine distribution inside, that may have made a difference to people because, again, like I said before, there's just this one healthcare provider that people have access to in the system. And so information-wise, I think that would have gone a long way. And I think if there had been a real effort to engage people individually, like one suggestion that we had in the beginning was to have an access, for people to have access to like a town hall, virtual town hall, where people in the community are actually able to engage, including medical professionals, engage with people inside. But that didn't actually happen. But I think that could have made a big difference. And in the counties, I think the reason the numbers are so much lower there is because they're still trying to do this individualized education piece and bringing in kind of health professionals from the outside to talk to people in more of a town hall manner. And because they saw from the surveying and from the initial rollout that there wasn't a lot of uptake. So in terms of what's over the top, I think being, again, dismissive of people's concerns as just kind of you're uninformed and we're going to address that by telling you like, look, this is an effective vaccine and you need to get over it, I think really is not helpful. But there's plenty of that going on still. And not just inside, right? Just in our communities and Black and brown folks, I think, have continued to be dismissed in their concerns. And that I think is probably the thing that's harming this process the most.
Thank you. And Rupali, what about from your lens? Like, are there just like do not do this take homes?
Yeah, I think the biggest one, to speak to that point, I think the biggest one is don't correct a misperception. So if someone comes to you and is really convinced that the vaccine can lead to something that it's not going to lead to, don't correct it. I do something called a pivoting approach. So automatically pivot and talk about severity and susceptibility of the disease, because we have found that if you do try to correct the misperception, people kind of dig their heels in, if you will, right? And sort of stand even more staunchly true in that misperception. And so that's one thing that we have definitely learned.
So you sort of change the conversation a little to pivot to another area that may engage them as opposed to trying to teach them that they're wrong.
That's exactly right. And I think we don't want to be dismissive of people's concerns. And so it's better to just pivot and say, you know what, talk about how many people have probably, you know, that essentially everyone at this point knows someone that has been infected, affected, or died from COVID. So I think to make it very real to people with regards to risk perception is the better sort of response there with regards to pivoting.
That's really helpful. Chastity or Shannon, anything to add there in the terms of the just like this approach would just be taking it a step, would be crossing the line, so to speak?
I think just the, you know, letting people out part, that to me is just the one that stands out, is because what immediately when COVID happened and they started releasing more people and they started, you know, furloughing and all these other things, it was so hilarious to those who are in this issue or even know this issue from whatever side that you could have been letting these people out. But suddenly COVID happens and you can release thousands of people. You know, it's so you need situations like this to kind of push the mindset of people who are in control, policymakers, bureaucrats, whoever is making the decisions on who gets out, to give them an excuse almost to do something that either they did want to do, but they felt they couldn't, or they didn't realize they could and should, and now they have to. And hopefully, you know, there's a lot of things that have come from this experience the past year that are good. I fear, as somebody just posted, Alison Jordan posted on the side, that there has been an uptick in incarceration after a decrease initially. So, you know, there are things that, not surprisingly, this is not something that's going to be here to stay. This is just a momentum, a temporary, contemporary momentum that we have, and we need to take advantage of it to get things to a better place. Ideally, you know, decarceration is the goal as much as possible, but just more or less not letting this be a moment in time and then we fall back into, you know, ridiculous draconian measures that have been upon us for decades now. So that's just the one that sticks out to me, is there should never be any release part to it.
Thank you for that. Chastity, unless you have something to add there, tell me. I'm going to pivot to one last question. I think that, you know, one other place I'd like to take this is we hoped to get to strategies to engage correctional staff and workers, and we really haven't today. And I think it's probably because we just don't know yet, or, you know, not enough things have been tried, or not enough attention has been paid on just how critically important it is, and what incarcerated people are saying, which is we want the staff to get vaccinated too. That's what we're hearing in a lot of arenas. And so to that point, Elizabeth, another provocative question, like, you know, I'm a healthcare worker. I'm mandated to get the flu shot. I cannot work in the hospital without getting the flu shot. They don't care what I think about it. I literally cannot take care of patients if I do not have my flu shot. That's for the millions of healthcare workers across this country. So to be provocative, why not mandate it for correctional staff and consider them essential critical workers who are engaged in the spread of an illness, whether or not they're aware, and ought to be therefore mandated? Can you talk us through your thinking about that?
This is a really, for me, I think a tricky area. There are lots of people on the ground who think that it should be required for the reasons that you just stated. And of course, for this population, these are the folks bringing it in, right? This is why we've had such devastating outbreaks. Correctional officers and staff have been the ones, of course, to introduce it. But it's tricky because you want to preserve agency. People should have agency and people should make informed decisions. And it's hard to sort of empower one community while saying that another can't have agency to do that. But again, for the reasons that you stated, it's so tricky because this is going, as long as we have prevalence in the community, and Chastity said this too, right? You can't, you're not going to get rid of COVID if you don't get rid of it in prisons. And there's data that has shown that the prevalence of COVID in prisons exacerbated community spread, and that decarceration has actually lowered community spread. So I haven't formulated, I should say, I haven't come down on a decision myself personally, and as an organization, we have not said that we think it should be mandated for correctional staff, and that we think people generally should have agency to make an informed decision.
No, I appreciate the nuance. I think it's hard to come down firmly on one side or the other. Rupali, I imagine you have thought through this in some ways, and I wonder what your thoughts are.
Yeah, it's a really tricky question. And, again, if I put on the hat of a public health person, we need to protect the health of the public. The best way we can do that is to get as many people vaccinated as quickly as possible, right? I think the flip side of that is, as I think we've sort of spoken throughout this, is that what does that do to trust? And does that erode trust for further public health initiatives in general, right? So when we need people to do something because there's a hurricane coming, for example, we need people to vacate their homes. And we struggle with this in, I think, a number of different ways. And Lisa, to your point too, I am an employee of a medical institution. I am required to get the flu shot every year. I don't have a choice. So I think that it is tricky. I think the reason that I have pause on this is because I always want to think about it from an ethical perspective, and if or not it leads to undue coercion, whether that's perceived or not. And that is sort of, I think, what I think a lot of public health individuals will say with regards to how they would determine how to proceed. With that being said, I think that there is a way to think about ways in which, again, my argument would be, how do we make sure people have the information they need to make an informed decision? And until we get there, then I don't really think we should really be having this discussion about, can we give whatever extra time to meet with family and so forth? Because I think, again, you're putting people, it's asymmetrical with regards to being able to make a decision that's based on evidence. And that's what we really, I think, need to focus on first.
Yeah, I appreciate that. And Chastity.
I think we have to look at it in this perspective too. Again, we have to make it make sense. So we have to look at it from the health perspective. In a perfect health world, that seems like that's what we should do. But we also have to think of the society that they work in and that those are incarcerated live in. Will this pose a conflict between officers and incarcerated people, to feel as though, well, they're not making you do it, so why do we have to do it when we feel like we don't want to do it? So it again becomes very, very, becomes a very, very sticky topic, because when you take away somebody's right to make a choice, then it poses a problem. So we have to look at it in the perspective of, like I said, where they work and where the incarcerated people live, and what kind of tension that may cause in that perspective.
Yeah, I appreciate that a lot. And I think that that's something that we've written about and thought through in other ways, which is like when it came to prioritization, right? Like, let's think of this again. We use the word ecosystem to name this webinar with real intention, that we think of this as an ecosystem. It's a system that operates, and where everything is intertwined. And that's family, staff, leadership, incarcerated people. And where the fates and sort of disease transmission, all of it is deeply intertwined. And so what I hear you saying, Chastity, is if you mandate one chunk of that pie, one slice of that pie to do something that the rest is not mandated to do, you interject area for additional conflict and distrust and all of the stuff that comes along with that, which is a really interesting thing for us to all think through, I think. I am mindful of our time. We have 1 minute left. I'm seldomly on time or prompt for anything, and here we've done it. I am deeply grateful. On behalf of Tyler, Emily, and myself, we are just so deeply grateful for all of the panelists who have taken 2 hours out of their day to share their minds with us, and also to learn and think through stuff together on the fly. To Bill Cordero, who's here translating for us so that people who like to learn and speak in Spanish can engage. And I would say, if there's anything that we've learned here today, it hasn't been lots of sort of bullet pointed answers, and that really wasn't the point. But we hope that that we've sort of called to mind again the deep and urgent need to involve the very people we are talking about today in the process. So this ecosystem, right, includes incarcerated people, family members, loved ones. We haven't mentioned clergy, but religious figures who are trusted, correctional staff, leadership, community-based organizations, advocates, and vaccine experts who have been doing this work for decades. And we ought to be learning together. We've also heard, and we've talked about this on a past webinar too, this stuff just lays bare how underfunded, understaffed, and how deeply mistrusted the correctional health system has been for really decades, and that we in the community have allowed it to be by allowing it to operate as a siloed system, truly disconnected from the community health system. So we all have responsibility when it comes to that. And hopefully this is an opportunity to create paths forward that build trust and that then just totally change how we think of health for incarcerated people and staff, and how we can build a future system that is never allowed to be siloed, in which that is always included in plans by departments of public health and community health agencies. And we think that through this, we can get to, better health and more readiness for whatever it is to come. So thank you, thank you, thank you. We will be transcribing this, like I said, and are really looking forward to sending this into incarcerated people to learn along with us and from all the discourse we've had here today. I'll also say that Shannon's group really, truly has put together really innovative informational stuff that's fun and engaging and really different than anything else I've seen. And so he has promised once it's like absolutely ready, he will share it. Some finishing touches left, but he will share it. I think that we will then help him disseminate it, because I bet there's a lot of people on this call who would like to look at it, have access, be able to send it into people.
You'll find all that information on our SEICHE website, which is now newly launched, kicked off. And so again, that'll be a place as well as our Twitter feed.
Thank you so much. We hope everybody has a good day, and thank you for your time.